Are we good now? All right. So, so function is a key determinant. Transfers for extension of the digits is a positioning motion and does not require the strength that, say, grasp requires. You need to consider the strength of the antagonist, and in general, the strength, you lose a greater strength with transfer. So transferring a reinnervated muscle that may be grade 4, it would not be optimal. Muscle force is proportional to the transverse cross-sectional area and independent of muscle length or excursion. And so here's a Blix curve that shows up on examinations, and at the resting length of the muscle is where there is maximum overlap of the actin and myosin, and that's where the contractile force is the highest. And as we progressively stretch the muscle, the contractile force goes down until load to failure. Sometimes you'll see an examination and they'll put a blank like, what's that? And you'll say resting length's the right answer. So the muscle amplitude is the total excursion at its maximum length with traction plus the length with stimulation. And the amplitude of the tendons is important. The long digital flexors, FDP and FDS, have 7 centimeters of excursion. EDC has 5 centimeters. The wrist flexors and extensors has 4, brachioradialis 3, and then the wrist tenodesis effect adds 2.5 centimeters. So let's say you have a rheumatoid patient with a fused wrist who has ruptured their extensor tendons. Well, you don't have the wrist 2.5 centimeters of additional excursion. So you might consider FDS transfer in that setting. So we all know that took physics, at work it's force times distance, and that's proportional to both the cross-sectional area and muscle fiber lengths and directly proportional to the muscle mass. And this I've just added, that this came out of Brand's book where he studied muscles, cadaver muscles, and studied their mass, fiber length, and physiologic cross-sectional area. And the measurable variable is mass. Mass is work capacity. Fiber length is excursion potential. And physiologic cross-sectional area is relative tension potential. And then, this is from JHS in 1981, every muscle in the upper extremity, he has their fiber length, their mass fraction, and their tension fraction. So the principles, and these were elucidated, best is, besides Smith's book, is the AAOS instructional course lectures with Smith and Hill Hastings. But what works, what is available, what is needed, you match the available muscles requirements, you figure out alternative procedures such as arthrodesis, and you stage for post-op risk position. So the algorithm is you have a complex paralytic limb, and you list the functioning muscles, you list the muscles that are expendable, you list the functions that require restoration, you match 2 and 3, and then you do the staging. So this is a spinal cord injury patient who needed thumb flexion, finger and thumb extension, finger flexion, intrinsic function, opposition, and adduction. And the stage 1 would be brachioradialis to flexopollicis longus, extensor carpi radialis to the FDP, and EPB for thumb opposition. We'll talk about that transfer later, FCU to EPB. And then all of these are immobilized with the wrist flexion. And then stage 2, for EPL and EDC, he did pronator teres transfer and thumb IP arthrodesis. Well, after stage 1, when you don't have intrinsic function and you transfer the ECRL to FTP, you have clawing. So only at the final third operation, you do the rebalancing, the brand transfers we just spoke about, ECU and plantaris grafts to the lateral bands. There's another concept called phase, and basically it's when you flex your wrist, your digits extend. So it's easier to learn flexocarpi radialis to the digital extensors than when you dorsiflex your wrist, your fingers flex. FDS is an out-of-phase transfer and can be a lot more difficult to learn in patients. You should not expect, anybody who's ever done radial tendon transfers and have had the pronator teres transferred to HIS knows that the FCR transfer is not going to dorsiflex the wrist and extend the digits. Each transfer has a single function, and you retain a wrist flexor and extensor. So if you got the OITE in front of you or the boards in front of you and they ask you to pick out these transfers, if you see a set of transfers that involves both FCR and FCU, it's not that one. And so we're going to start off speaking about radial transfers. I also had the opportunity to be Bill Littler's last fellow, and he was quite the, he could really draw and paint. He was quite the artist as well as an artistic surgeon. But here he shows pronator teres to ECRB, basically taking the passive hand of man, and here's the hand of God. And the weak hand of man, as from the Sistine Chapel, Michelangelo showed, demonstrated man's weakness with the radial paralysis and the wrist drop. So the Jones transfers that we spoke about a few minutes ago involves the pronator teres to the central wrist extensor, the ECRB. When you take the pronator teres, there's really not a lot of tendon there, so you have to work hard and go out on the radial periosteum to get as much length as you can. Then there's the question of the flexocarpi radialis or the flexocarpi ulnaris to the digital extensors and palmaris longus to EPL. If they don't have palmaris longus, you can use a FDS. This does not sacrifice a digital flexor and preserves grip strength, but it has no independent digit extension. But both the FCR and FCU are in phase with EDC. So which do we prefer? This has been, when hand surgeons historically needed to debate something, this was one of the debates. But my training and thinking is that flexion ulnar deviation, which we now call dart thrower's motion, such as swinging a hammer, is compromised with the FCU transfer. The transfer for digital extension is positioning and requires little strength, and FCU has twice the strength of FCR, so you may be squandering wrist strength with the FCU transfer. Forearm rotation requires wrist flexion ulnar deviation. And then with the posterior interosseous nerve paralysis, where you have an intact ECRL, FCU is the antagonist to ECRL, and you could accentuate the radial dorsiflexion deformity with that transfer. So I like FCR through the interosseous membrane. It's a straight shot, just proximal to the pronator quadratus. Then another Los Angeles hand surgeon was Dr. Boyes, and he was actually one of the people that Dick Smith did his fellowship with, and an entire school of hand surgery. But his transfers were to provide more independent digit extension. So he kept the pronator teres to ECRB, and then the ring FDS would be to the middle ring and little fingers, and then he would transfer the middle finger FDS to the EPL and index EDC to get some independent extension. There is less grip strength, and this is an out of phase transfer and can be more difficult to learn. And you can see he also added in some patients transfer of the palmaris longus to the abductor pollicis longus to augment thumb abduction. This just shows harvesting the middle and ring FDS. There's a window radial to the neurovascular bundle of pronator quadratus, and then with the dorsal transfers. And this is sort of a sandwich technique to the more ulnar three fingers, and just testing the tenodesis effect on the operating table.
Can I ask a question?
Sure.
Which way do you go with those tendons? Do you go through or around?
The FDS?
Yeah.
I go through the interosseous membrane. Take the, I mean, you can, I mean, there's a lot of people will take the middle finger FDS and go radially around the FDP and the ring ulnar around the FDP. I like going straight up through the interosseous membrane. So with thumb loss of opposition, there is paralysis in these three median innervated muscles. Opposition requires the thumb pulp to be opposite the middle finger pulp with the plane, true opposition, the plane of the thumb and the plane of the middle finger are the same. And opposition involves this, you'll see this on exams too, abduction, flexion, and pronation. Number one principle is to first correct the first web contracture. This is a positioning transfer that does not require a lot of force. The transfers must approach the APB insertion at a 45-degree angle from the pisiform, and a hypermobile first MP joint may require arthrodesis. So these are the standard transfers, EIP to abductor pollicis brevis, the standard Benel transfer, ring finger FDS to the abductor pollicis brevis. The Kamets is the palmaris longus to the abductor pollicis brevis, and that is used primarily in bad cases of carpal tunnel release, of carpal tunnel syndrome with thenar atrophy, and it's a prolongation of the palmaris longus with palmar fascia. It is not a true opposition transfer. It's an abductorplasty because it does not approach the APB at a 45-degree angle. Then there's the Huber, the abductor digiti minimi equini transfer, and then this ECU to EPB. I recently did an ECU to EPB transfer, and this was a lady who had had a number of transfers elsewhere for radiation-induced plexopathy, which a lot of times they just progress over time. But her thumb was out like this, and someone had told her they could fuse the first CMC joint, but she did have available ECU. So the principle is you divide the EPB at its musculotendinous junction, bring it obliquely across the palm, and bring the ECU around to the EPB, maintaining its insertion. So, you know, it's a rarely used, but it can be helpful. So I like this transfer, the FDS of the ring to the APB. In fact, you need a pulley. I think it's the most predictable result. Of course, it's unavailable in high median paralysis. So Charles Ed Irwin was the first hand surgeon in Georgia. He was FDR's doctor. He was a polio surgeon, and he ran Warm Springs. He did his surgery in Atlanta at Piedmont. He died about 1955, 56, and his fellow was Leonard Goldner. So if you were trained by Lamar Fleming, or if you trained at Duke, or if you trained under Gilberman, or if you trained under Andy Coleman, to name a few, you are a lineal descendant of Ed Irwin. He's really the true father of that school of hand surgery. And the reason I show this transfer, this was from JBJS. I got it here back in the mid part of the 20th century. The transfer actually goes into the radial proximal phalanx, and that would augment pronation. There she is. I told you I would have a surprise for you. So Nikki did this study, studying the pulleys on the ulnar aspect of the wrist. And if I interpret this right, you found that the less friction was either around the intact FCU or the 3.5, the big loop, right? So, but it's and that's a great paper, great contribution, and diagram goes really nice in this talk. So now we come to the EIP transfer. You would think it'd been around a long time back in the polio days and so forth, but it really came later out of the Vietnam War. And it was initially done for high median nerve injuries and combined median and ulnar nerve injuries and 2 brachial plexus injuries. But it's, so often when you have median paralysis, a low median paralysis is scarring about the volar wrist. The FDS may have been injured. And so this brings in an uninjured tendon. There's no loss of grip force. You retain FDS. There is no pulley, and it just reaches its insertion. You sometimes have to go a bit out on the hood to increase the length, and it's available in high median paralysis. This is a patient that I'm going to show you some pictures of her. I've had this case since the last time I gave this talk, so I've added it. This is a 15-year-old girl with a Chiari malformation with complex intrinsic loss in each hand. But this was pre-op, and this was first post-op visit after an EIP transfer that I've started bringing them around the pisiform and out. And she had really hypermobile first MP joint, and I went ahead and did a first MP arthrodesis at the time of that procedure. And we spoke about the Kametz transfer. It's not a true opposition transfer, but if you're doing an open carpal tunnel release and you want to give the patient a little abduction right away, it can be useful. And then we have the Huber transfer. I'm sure when y'all rotate with children, you probably see, I would hope you see this a good bit. Used primarily in thumb hyperplasia, recreates a thenar bulge, and it can also be used in combined median and radial paralysis for some mixed brachial plexus type injuries. So this is a first web syndactyly that is treated with a dorsal rotation flap and full thickness skin graft, and you can see the thumb's really still functionless out in the plane of the hand. And then after the transfer, the thumb's quite useful and opposes reasonably well. I sent you a copy of the paper I just did. It's in the JBJS Open Access, just came out as a paper on, Michael asked me to do a talk on a couple of years ago at Georgia Hand, and I said, well, I think I'll do one on First Web. And so we just wrote it up and got it published, and this case is one of the cases in it. It's in the Open Access, JBJS Open Access. Okay, so power pinch is associated with ulnar paralysis, and the several signs that are helpful to know. This is another Littler drawing showing Froment sign, where it's the compensatory interphalangeal joint flexion due to the paralyzed adductor and first DI and compensating with the flexipalacis longus. Then there's Jean's sign, which is first MP hyperextension with pinch, and Bovier's sign, which is also we see in the digits, but it's loss of full IP extension with MP hyperextension and corrects with the MP inflection. So this is, you know, I used to talk about using an FDS transfer. You can do it through the carpal tunnel or through the palmar fascia, but Dr. Smith's transfer is just really, it's hard to beat. And it involves the extensor carpi radialis brevis transferred through the second intermetacarpal space. And this drawing is from his original paper. So with paralysis of the first DI and adductor, the adductor has the largest of the intrinsics cross-sectional area to volume, is most powerful intrinsic. And these two muscles together are 75% of the thumb adduction force. So what's the other 25%? Thumb adduction. Extensor pollicis longus. So what we're doing when we're restoring power pinch is replacing or restoring the function of the transverse head of the adductor pollicis. And this is the ECRB tendon transfer, and it basically involves 4 incisions. You detach the ECRB here, you pull it back dorsal to the second dorsal compartment, and then bring it distally, and it requires, according to Smith, tendon transfer from the adductor through the second intermetacarpal space, and then the tendon juncture is here dorsally. It doubles the pinch strength. It's my go-to procedure. And some of our other Atlanta friends, Glenn Gaston, when he was a resident, and Gary Laurie, they wrote in hand clinics a few years back, Z lengthening rather than using a tendon graft, and then stabilizing the IP joint with a split FPL. And then they talk about arthrodesis of one of these joints. I tried this and doing a strict Z lengthening, I had a hard time setting the tension. I can see doing a Z and then dividing it and setting it, but I like to do that distal insertion first. And so it was, but hey, look, when you're in situations where you're doing a brand reconstruction and this, you need all the tendon you can get. And if you can do a Z lengthening, I think this is a good, you can use that ECRB tendon as donor, either with a Z lengthening or as an additional tendon graft. I think that's a good option. And, you know, this is just a case on the table. There's the Froment sign. And you can see after this tendon graft is inserted, the adduction to the closing the first web. You can see I was going to do a first DI transfer as well. So speaking of first DI transfers, you can use prolongation of one of the accessory slips of the APL with a tendon graft to the first DI. You can use EPB, fuse the first MP and use EPB plus a graft. You know, they talk about transferring the EIP to the first dorsal interosseous, but that's not much of a vector. I think you get a better vector coming across. Some will describe actually transferring the tendon into the ulnar base of the proximal phalanx so that you get some flexion and supination of the index finger to improve power pinch.
Do you feel like this does a lot? Like
I think that I don't think it does a lot.
Are you talking about the ECRB with the palmaris graft through the second round? Like
No. This FDI.
Yeah. I don't think it does a lot. I think if you have a hypermobile, hypermobility, it may help. If you've got a real stable second MP joint, I don't think it makes a lot of difference. And I think that's something to evaluate beforehand. And I'd probably do as many ECRBs without the first DI transfer as I do with it. But as Michael was suggesting, the ECRB transfer, it's a great operation. I think it's 50% increase. Patients like it. It doesn't necessarily correct the Froment sign entirely, but it goes a good way towards it. Okay, here's another sign for intrinsic paralysis, the Andre Thomas sign. Okay, this is from 1917 French literature, and it's flexion of the wrist to improve digital MP extension that actually worsens clawing, but it's a subconscious effort that you'll see patients with bad intrinsic paralysis do. Okay, so clawing. You'll note with clawing, the fingers push the object away. They're trying to grasp. You can see it. The index finger is not as severely involved, but we'll look at it again. So they cannot flex and extend the interphalangeal joint. So she's using her thumb and her index finger, but she's unable to get her middle ring and little fingers around the mouse. Okay, so these are sagittal bands. But my question is, what's this structure? And what's that structure? That's not a sagittal band. That structure that goes that way.
You're talking about the transverse fibers?
I'm talking about the transverse fibers. Yeah. Right, okay. And who can tell me what the transverse fibers do?
If you guys watch Dr. Posner's Handy 50, it's the same talk I have that I give to y'all occasionally that talks about the transverse nerve fibers of
right. So the transverse fibers flex the MP joint. Okay. So don't ever call that the extensor apparatus. That's the dorsal aponeurosis. The sagittal bands, just proximal, extend the MP joint. These oblique fibers extend the PIP. It's controversial whether they extend the DIP or the ORL does. Probably a little bit of both. But so Ben Fowler was another Southern hand surgeon. Bill Littler, who was in the Army with him, always referred to him as that genius, Ben Fowler. He was he really later was in Nashville, and you can read about it in volume 31B of the JBJS before the British Orthopedic Association. And he said, as the EDC has no insertion into the proximal phalanx, the inability of these tendons to extend the interphalangeal joints of the claw hand is due to hyperextension of the MP joints. If such hyperextension is prevented by capsulodesis or tendon transfer, the EDC can extend the distal joints. Now, we think now everybody knows that. But in 1949, that was a seminal thought. So to restore intrinsic function, you must achieve MP flexion. Your transfer must pass volar to the MP joint and truly volar to the intermetacarpal ligament. And restoration requires prevention of MP hyperextension and a force to initiate flexion. So here's Bouvier's test, where this patient's MP joints are blocked in flexion, and she's able to fully extend the interphalangeal joint. So that would be simple clawing. Complex clawing would be inability to do that. So with simple clawing, you can address the clawing with either a static tenodesis or capsulodesis of the MP joint, transfer into the transverse fibers of the dorsal aponeurosis, or transfer into the proximal phalanx. Complex clawing, you would need to transfer distally into the oblique fibers that extend the interphalangeal joints, usually with either the FDS or a brand foretail transfer. So this shows a tendon transfer into the lateral band, into the oblique fibers. This shows a transfer into bone. And this transfer is around the A1 pulley. And that's a Zancoli transfer. And the Zancolis, they're a father and son. They're brilliant Argentine hand surgeons. You think all they do is paralytic stuff. And then I read, when I was doing my paper, I saw where they published like 100 PI posterior interosseous artery flaps. So they've done a lot of work. I've always done this, done the Zancoli procedure around the A2 pulley. But do y'all have a preference, A1 or A2? I think you get more of a moment arm around A2, but it can be about either. So the Zancoli procedure achieves MP flexion. It does not increase grip strength, and it's useful with diffuse paralysis where there are limited donors. Now, so here's another question for when you're taking an exam. They'll ask, which one of these transfers increases grip strength? Well, it's always the one, just about always the one where you bring a wrist motor in, because that's when you're adding strength. When you're using an FDS is already there. I promise you'll see that on the exam.
Do you like the dynamic transfers such as the lasso versus the actual capsulodesis, like the bull or plate tethering?
It depends on the situation. I'm going to show you a case in a minute that I did the capsulodesis because the FDS was too weak. But I like them both. I don't have an idea. If you read Eric's paper, the lasso worked pretty darn well in that one that y'all published in PRS. And so I'll tell you, doing the capsulodesis is hard work, I think, but it can, I'll show it in a minute. So if you have a low ulnar paralysis, you can use a split middle finger FDS through the lumbrical canal, and you can either go into the, depending on if it's a type, simple or complicated, into the bone or the aponeurosis. If you have a simple Bovier or simple clawing, I would try to avoid, I would prefer going into bone or into the transverse fibers, particularly with patients with hypermobile joints, because you can get hyperextension of the PIP and induce a swan neck deformity. This is just a case with intrinsic paralysis where I used both FDS, and these transfers go into the radial aspect of the ulnar 3 digits, but into the ulnar aspect of the ring, you don't have a transverse metacarpal ligament in the first web. So we're back to the brands. He classically used plantaris grafts through the lumbrical canal, motored by a wrist flexor or extensor. And as we said, adding the wrist motor actually increases strength. And so here's ECRB, and then you can actually aid with a volar incision. Here's a ulnar incision on the index, and then you take a plantaris tendon and make a four-tailed graft, and pass those palmar to the intermetacarpal ligaments, secure them distally, set the tension proximally using the wrist motor. So this is not really a tendon transfer, but it's an option. And this is a group of people who actually trained with Dr. Boys, and it's a good paper from JBJS 1972, where they evaluated their capsulodesis procedures. And also this drawing is out of Bonnell's original text, and it shows what's termed pulley advancement, which basically is release of the A1 well into the distal A2 pulley to increase. You see this angle here, it increases the moment arm and can aid in MP flexion, and you can use that in combination with capsulodesis. So this patient was the one I showed a few minutes ago with the clawing, and her FDS were not amenable to transfer. So I did, and you saw her index finger wasn't really involved. So I did a first MP arthrodesis and an EIP opposition transfer, and third, fourth, and fifth MP capsulodesis. And so there she is. You can see immediate first post-op visit, she's able to grip the mouse, the same mouse, with her with all 4 digits. So definitely in that case, I like the capsulodesis. I used the Arthrex system with the internal brace. I hope that holds up over time. It's a young woman. But that was the.
When you did that, you put one anchor on each side and the internal brace in the middle, or you just put the anchor in the metacarpal head?
I put one anchor on each side. Yeah, just like you, like I'd put a swivel lock on each side. And I used, and in the, also took the volar plate and I brought it down to the proximal swivel lock, tied that, and then brought the suture tape distally to the proximal phalanx. So this is Eric's paper. I think it was a review of multiple publications, but it basically showed the best grip strength was with the Brand procedure, but the best correction of the claw deformity was with the FDS lasso. And I think that's good to know, man. And then down here for pinch, just the tendon transfers can improve pinch, but that's so one approach to the patient with intrinsic minus hand that you can, if you really have time and want to do a lot of work in one day, is you can retain the ECRB and you can do the ECRL as the adductorplasty. You can do the index abductorplasty. You don't need to. You can use the ECU to do the Brand reconstruction, and you can do that with bilateral plantar, so possibly one plantaris and an ipsilateral palmaris longus, and all of those transfers are immobilized with the wrist and dorsiflexion. Okay, so with the proximal median nerve paralysis, you have this, and loss of opposition, loss of FPL, and index flexion, and the brachioradialis works well to the FPL, and you can buddy transfer the index FDP to the the middle FDP is, we know, is double innervated. You can transfer it to middle FDP and then do EIP. Opponentsplasty, all of those are immobilized in palmar flexion. If you have both proximal, median, and ulnar combinations, you can do the same type of transfer using ECRL to the digital flexors and EIP opposition. And the clawing does not become apparent until FDP is restored. So you have to come back as a second operation to rebalance. And so this is basically what I just said. So if you have a combined high, median, and radial paralysis, your only wrist motor is the FCU. And this is a case where you can do the wrist fusion and transfer the FCU to the EPL and digital extensors, and you can do the Huber transfer and index FDP to middle FDP and replace FPL with a thumb IP fusion.
During fellowship, they always used to ask us why brand or how is it that brand could go through the carpal tunnel to do some of these transfers, right? I don't know if you've ever noticed that. You know, he used to, a lot of the original transfers used to actually go through the carpal tunnel.
Right.
And we can't do that for most of the transfers for the issues that we have. I don't, do you guys know why? It's because he was operating on leprosy patients, right? So they all had dysfunction of the nerve because it was a superficial cold nerve, essentially, which is why it was affected by leprosy.
Yeah.
Yeah. That was one of the favorite questions.
That's a good question. That's right. And why does the rabbi bless the food like this?
I shouldn't have just by no idea.
Why is what? Say that.
Why does the rabbi bless the kosher meat like this? Because he couldn't do that if he had leprosy.
So you know you got clean videos.
Well, he's clean. That's right. So, so with brachial plexus injuries with tendon transfers, the lower plexus is basically the same principles as the distal peripheral nerves. Upper plexopathies, you can lack elbow flexion, lack digital extension. You can have a mixed picture on what's functioning and shoulder girdle weakness. And so a stage 1 transfer can be a standard transfer for thumb and digital extension. One of my points is you want to use FDS if possible rather than a wrist flexor if you're thinking about using a Steinler flexoroplasty for a second stage, since it does not arrive from the medial epicondyle. So these are pretty standard transfers. I say standard, they're really not. The pec major should to be condemned. The bipolar latissimus, according to this study, produces the greatest strength. The pec major is cosmetically deforming and may destabilize the shoulder. The triceps to biceps, you're sacrificing extension for flexion. And this is a lady who had already had the boys transfer for digital extension and could not flex her elbow. And that's a Steinler flexoroplasty with the flexor pronator transferred to the anterior humerus. And she's got that flexion contracture, but she's got that much flexion.
You just didn't like the idea of doing bipolar.
Well, she had paralytic changes up around the shoulder. And
we had a couple of those in fellowship. It was actually pretty neat.
Steinler's?
No,
bipolar, yeah. Yeah. Yeah.
So essentially, in case you guys, if you have not seen or done it, you essentially take latissimus off of both origin and insertion. Take essentially the insertion where it is, and you go up to the forefoot, and you essentially take the other piece. You have to, obviously, it's a fairly long muscle, so you have to shorten it quite a bit to get it into the distal biceps potentially accordingly, or you keep the pedicle attached, so it's not like it's a free muscle transfer.
Yeah, it's been years since I've done one, and it was a plexus injury. I didn't. Okay, acquired tendon ruptures are usually attritional with mop ends requiring tendon transfer or intercalary tendon grafts. Just rheumatoid. We know about y'all know about the Mannerfeld lesion. It's osteophyte over the. Tell me what the Mannerfeld lesion is.
Joanne, work here, one of you.
Well,
Close. Here. It's ST arthritis that causes FPL.
right. There you go. And see the.
Seen it a few times, Jack.
Yep, you'll see it. And there's the scaphoid, have a scaphoid osteophyte, have a trapezial osteophyte, STT disease. That's the Mannerfeld lesion, and it's usually ruptures the FPL. Sometimes it'll rupture the FPL and the index. And the treatment for the FPL rupture, one treatment, and it's not a bad one, is IP fusion. Another treatment is an FDS transfer, and another treatment is an intercalary graft. And I kind of go back and forth on it. I've about decided if I go into the forearm and I can see any distal FPL, then I'll do an intercalary graft if they have a palmaris longus. And if I can't, then I'll take an FDS and go all the way to the tip of the thumb. But I always offer them an IP fusion. And then now the Vaughan Jackson or Caput-Ulna syndrome, y'all know about this. It's arthritic changes at the DRUJ, begins in the more ulnar extensors. I had a lady come in last week and she looked like this, okay? She just looked like that and never been diagnosed with rheumatoid arthritis. Her wrist didn't look that bad. Got an x-ray and her sigmoid notch was just, just washed out. And you can tell them when the first tendon goes, I mean, I've had patients come in like that. You book the surgery in 3 or 4 weeks and all of them are gone when they come back. So it's not an emergency, but it's urgent. When they start dropping tendons, hop on them. And you need to address the DRUJ. That can be with distal ulnar excision. It can be with, in some patients, they're just osteophytes that have herniated through the floor of the extensor compartments. You can shave down osteophytes and repair the perforation.
So what would be one of the cases where you do not want to take out the distal ulna? Why? In an RA patient for the wrist. Right? So if you can take out the distal ulna, what can't you have on the x-ray? Or what would worry you if you took out the distal ulna? Assuming you're not going to use the wrist. Ulnar translocation.
That's right.
So that's a common test.
Yep. And so you can shave down osteophytes, or what else can you do in that setting? You're not going to take out the end of the ulna and you have ulnar translocation. Swabi Kapanji. That's right. I tell you, it's a good.
It's not leaving that. I do it almost.
Doesn't believe it. Go on.
It's like a strong word. It's like
Well, how do you manage the ulnar stump when you do it?
I do modifications that bring their stabilization, so in ECU, do itself.
Same way I do it. Yeah, that's what I do. Yeah. Jupiter Trumbull. Yeah. Well, it's got its indications.
look, it's just like everything else. It's all about, just like most of orthopedics and hand surgery, it's all about identifying the patients and identifying the correct operation.
Right.
Sometimes there's multiple. Sometimes you're really pigeonholed into doing one or two.
If you do a Suavi-Caponghi and you have an unstable ulnar stump and you get convergence, they're miserable.
HOS,
What does that stand for?
undershift.
That's right, exactly. And it's hard, it's not a good solution then. Okay, so when you have the rheumatoid tendon ruptures, they start ulnar and they go radial. So if you have the extensors to the little finger ruptured, what's the transfer for that? It's all up there. Okay, you do your buddy transfer to the EDC to the 4. Okay, let's say if you have EDC4 and the little finger extensors out, what do you do then? You transfer EIP.
So be very careful. So what you just said is actually something that one of our previous fellows mentioned during their boards. And they're like, well, I don't understand why they had a whack. I said, because you missed one of the principles of what we talked about, right? So I want to go over that answer because it's actually a very important principle. So what you mentioned is you said if they have their 5th and 4th EDCs out and the EDQ, so essentially these 2 are dropped, you can't just take these 2 and put it and decide into the middle. Because the problem is you're asking a single tendon from the middle to navigate all 3 of these fingers, and it doesn't have the force or the cross-sectional area approximately to do that. And so your options now, your only good option is to actually transfer your EIP because it has enough cross-sectional area that it can power 2 fingers. Can't power 3 because it's not really, you're not supposed to, but that's part of the issue.
That's right. And let's say if you have, what do you do if you have middle ring and the 2 little ones out? You buddy middle to the index, you buddy middle to the index EDC and transfer EIP to the ring and little. And if all 4 are out, you go, oh crap, and you do the FDS transfers that don't usually work as well.
There's actually a very important slide because often these are the people that will come into you and you don't realize, and you get in there and then you think you have potential stuff, but you don't realize what you actually have until you get in there and you're like, oh crap, there's way more out than you expected.
Yeah.
Because often some juncture or something may be tricking you into
That's
what's
exactly.
in and what's not.
That's
Do
right.
you like FDS because of the individual nature of those, or require you not to SCR transfers?
An FCR transfer, because usually it doesn't reach the distal end of the tendon. I mean, it's tight. I mean, the FCR is not, that's the main reason. And, there's some people who will just take a wrist extensor to transfer into the ruptured digits. But
Wait. So, Joanne, what's the problem with that? I was just asking about a wrist flexor. Why am I asking about a wrist flexor to use instead of a wrist extensor?
Mentioned it earlier in this talk.
Which I would just consider this like phase when you're
Yeah,
actually
that's
going
right.
to
That's right.
Yeah.
FDS is well, FDS is also not, that's what they are.
and Eric's question was, why not use FCR? And if the distal tendons were sufficient length proximally that FCR could reach them, I think that's a great alternative. But it would be tight. And
I had this case come up this week. I've got a guy that's pretty rough.
uh-huh.
I saw him, it was 2.
Yeah.
Wait on surgery. Okay. And he called us in now.
Were you here when I said that a few minutes ago? Yeah, right. Yeah, it's one of those things where it's just like tendon transfers for radial paralysis and tendon transfers for extensor ruptures. Be sure and examine the patient that day because the radial nerve will frequently have recovered and the extensor tendons, more of them may have ruptured. And then we know the non-displaced distal radius fractures are the ones that are associated with EPL ruptures. The EPL is held to the fracture site by the 3rd dorsal compartment. And the treatment for that usually is EIP to EPL. But Dr. Littler has a good series using intercalary palmaris longus. So either one of those is an option. And this is a X-ray of one of my patients. And I like to take the EIP dorsal, take it back proximally, rather than doing the transfer, just moving it from here to here. Take it back proximally so you come back dorsal to the retinaculum. And now that we're in the days of Wallet, oh, well, there we go. Well, anyway, this is doing wide awake local anesthesia, no tourniquet, and having the patient you can set the tension just right with the patients.
I'll be able to help you much more. Because usually you can make it to full screen. Where's your mouth? I thought you could get it to go. I'm not sure. I don't want to ruin it.
Well, it's a good. This procedure. I mean, we read Don Lalonde doing flexor tendons under this technique, but this EIP transfer is very amenable to the Wallet, and I'm sorry that's not working. And then I just throw in a bit about the now that we are all fixing radius fractures with volar plates. The FPL rupture is the most common, but you can get extensor ruptures. I think most of you know about the song grading, and it's I think usually you can pretty much tell if you've perforated when you're using fluoro, but this is all you need to get an EPL rupture. And this is my case. I didn't do the first operation, but I inherited this case. See that perforation there? Maybe a little bit here too. Got all 4 tendons. So that case, I did FDS I don't think FCR would have reached that, Eric. It'd be a little tight, but I'd
Sure, that's up in the hand. I mean, the rupture more at the wrist.
ruptures at the wrist, yes, sir. And that was FDS transfers distally. And so really, we only need the studies show we really don't have to go tickle the dorsal cortex when we do these cases. All right. Is that enough? Thank you. Thank you. Thank you. Thank you. Oh, thank you. Thank you.
Tendon ruptures is one of the more challenging things, I think, at least as a fellow master. Trying to memorize stuff. I found memorization goes up really works. My advice to y'all is like, don't do what I try to do and just get a bunch of like greens and so you great tables or great tables of all different options. Like actually try to understand why extra options. Really click me and sort of understand. So if we really recommend going to memorizing things, try to understand like and then there's exceptions for sure. Start with that. It's intervention in general. I mean, around the hand, this should look like so many functions. This is beautiful. I'm going to try to conceptualize. That's hard.
I think it's because I wish you kind of wish patients showed up with like a single nerve issue that's out, right? I think that's part of the problem. It's like simple isolated radial nerve. You're like, I got this.
Yeah, hell yeah.
And then the best part you look like there's no palmaris. So
yeah, that's right.
Right. So there's always something.
And like the pronators out, somebody fixed the radius.
Yeah, there you go.
I mean, there's typically, there's often stuff. I think the harder one is where you have mixed nerves that are injured. That gets a lot more difficult when you're starting to do some of the things when you've got mixed nerve patterns. You're not sure what's in, what's not in, and how strong.
Yeah, plexus issues, and I really enjoyed that recent case I showed of the Chiari. That was gratifying, but it was one where you don't just sit there and say, "Oh, we're going to do this. We're going to do the Jones on you."
So let me ask you this question. For
Yes.
those people that come in with what I would consider super complex issues, do you make the decision on the first time you meet them, or do you bring them back a few times?
Both, but sometimes I bring them. I mean, one, I do the examination myself. Some people will send them off to therapists to have the examinations done. Yeah, but I'll do the exam myself, and usually I outline a treatment plan. That young girl that I just showed came from a long way away, and she came down, and I did the simple side first, which was the first MP arthrodesis and the EIP opposition transfer. And then I examined her 2 or 3 times before I went and decided to do the capsulodesis. Yep.
Can you explain again, for some of these that are more complex and need multiple transfers, how you plan each stage? Is it position of the wrist?
Right. Well, let's say tendon transfers for median paralysis are just about all done with the wrist and palm flexion. Tendon transfers for radial paralysis are done with the wrist and dorsiflexion. But so if you have a combined paralysis, you would choose the tendons that I usually choose the ones first that are immobilized in palmar flexion. And then second would be dorsiflexion. And then the example I showed was after you've done those two, you've got a claw hand, and then the third procedure would be the rebalance. Now, let's say you have a patient who has combined median and ulnar paralysis at the wrist, and you want to do a opposition transfer and an adductorplasty. Always do the opposition transfer first and get the thumb out and get the web out, rather than doing the adductorplasty and having a tight first web and then doing the opposition. So I mean that's a rather simple example, but that's the type of thing.
And how long do you give them between stages for them to reprogram their brain to learn?
Well, if it's EIP opposition transfer, they learn that right away. But I normally would give 3 months just to let the tissue settle down. And also to make sure they need the operation. Okay, I'll come back anytime. I got package talks on microsurgery, microvascular surgery. I got a good talk now on the first web. So y'all just tell me I'll come.
I think one of the things that would be beneficial, so we get the specimens, maybe to do like a lab and have you take some of the fellows through maybe some of the more common transfers.
That'd be fun. Yeah.
Do that. Maybe we figure out a time to do that. I think you guys would like that. Yeah, you guys can take pictures or videos. Use them as you guys please. That may be a good thing.
Do Mondays work for you? Or
yeah, Mondays are great.
Fridays work better for you? Or?
Fridays, no. I reached a point in my career. Just this summer, I turned 70 and I gave myself a present.
Fridays off.
Fridays off. That's my first step. Fridays off. But any other day I can make work. So in these thumb drives are Dr. Smith's book, and then an article by Dr. Smith on balance and kinetics of the hand under normal and pathologic conditions. Just a classic paper. And if you know everything in that, next time Michael does the intrinsic has the questions, you'll know all the answers. And maybe, just maybe. And then also I have this paper, this presentation is on there.
I think I told you this before. My fellowship director shared offices with Dick Smith.
Oh, absolutely.
Oh yeah, the two of them have their office. It's still there, across from the Guggenheim, next to Central Park.
Wow, yeah, they were there. Littler is 14 East 90th Street, across from the Metropolitan, just right in the same neighborhood. That's great, and they were both Well, you know, they were both Emmanuel captain trainees.
We should definitely take that book, because
That was
it's
a-
Smith book, it's not.
That's the name of the fellowship that I did, the Manual Captain Fellowship.
And that was who, you know, that was who really got Smith. Both of them made hand surgeons out of both, each of them. Wow. Have you seen Littler's drawing of Emmanuel Kaplan?
So I actually, as you probably know, Steve Whittle,
Yeah.
I forget what year it was, but he had, I must have been there actually, I was a fellow at the time, so this was 2014.
History of hand surgery in New York?
Yeah, correct. They had the whole library
Wow.
of his drawings out and open at the one thing, and we all took pictures. I mean, I've got plenty of pictures. I took a bunch of different pictures of all the various Littler drawings that were phenomenal. And then he had the book. Eventually, Steve did the book of the Littler drawings, which I have.
I got about 30 drawings in there that I donated.
Which were pretty neat.
Yeah, and I'll tell you, in my last will and testament, I'm serious, my Littler collection goes to the New York Academy of Medicine. 'Cause that's where he put all of his stuff, and
Did it make a stop that they were in hand with the sort of?
well, you want to? I can do that, you know. I would, but hopefully I'm around a lot longer, but I am. I'll tell you another thing though. Y'all may know this. I think that Eric Michael may know it, but there is my dad, my granddaddy, and my great granddaddy are all doctors, and their honor I've established the Dr. Floyd Scholarship at the Emory University School of Medicine for 4 people from South Georgia. Yeah. Okay, guys, don't lose. Oh, y'all got it. Okay.
Yes, sir.
Well, you're amazing. Thank you so much.
Thank you. I enjoy it. Anytime.
What are your thoughts on, what are your thoughts on February 10th? Right after our interview, I started doing a nice natural transition. All of us should be here because we all.
How about you?
Emily, now, do you want, would you rather have microsurgery or first step?
Go ahead and hear. What would you guys want?
Would you rather have a talk on microvascular surgery, reconstruction, or first wave? You've heard the micro talk. There's some overlap between them, obviously.
30 minutes,
Here,
Yeah.
would you like the micro?
Run the micro talk or the first web talk? Perfect. First one.
First wave.
I think you just put a dagger through Nikki's.
Rude.
Okay, I'll tell you what to do. Go to JBJS Open Access this month and read the first web talk. I just published it. Read that,
Take the fun.
and then we'll do the micro talk.
Wait, are we taking a picture?
We're gonna take a picture.
For the Instagram. Can you come at 1, do you think? Are you guys actually with them?
Yeah, I can do that. Yeah.
That would be cool. I'd like to see some of his.
Yeah, of course, that's right. That's why I said.
Where-
Great idea. You have one of the real experts in our backyard.
That's why I cut it. That's my idea, it was so good, I said it.
That's actually.
Well, he actually wanted to. Remind me, at some point, didn't you say you wanted to reconstruct one of the books?
I'd love to do the Smith book.
Yeah, so one of the options we could do is try and actually get a bunch of cadavers, get some high level pictures.
That's right. I love
Now
that.
with video as well, we have GoPro, so if you're willing to wear one of Eric and I's GoPros, we can actually, you can video in real
That's
time.
what I say. Let's go our GoPro ride the horse.
And then we can, as long as you're not falling off the horse, but we can get some of those stuff. All right, so we want you.
Oh, good. All right, great.
He's coming, Monday after our interview.
Okay, great.
And he's coming in, he'll be here at 1.
Julianne, you can't miss this.
Check them out.
Keep my jacket on.
Check it. Not yet, not yet.
Right, 3, 2, 1.
Thank you. I saw your paper.
Yeah, thanks for putting that in there, I love that.
All right.
So I do.
Super awesome. Back there.
Right.
One of my mentors those guys, Ricky has
So he's got a, oh, and he has a non.
Oh, I've never done that, but that sounds good. Ricky Alice has elongated with FCR using just the tendon. Okay, okay. Sounds pretty cool. Do you get with it? It has the elbow. It's kind of asking what possible to do.
I do.
Right.
When they bend their elbows.
That's my problem, like Ricky Alice.
And when you have your, you need this.
Yeah.
Yeah.
Right, yeah. Although I
It works for the scalp. The way it works fine. That's the thing about We'll wish to see how much nerve transfers are going to make tendon transfers.
I got this
yeah, I agree, and I think if you can get that, have such that would just do that. I wouldn't.
And he had
But
a.
if you don't have subscat, I would relax it.
Subscat, and then we'll try to-
Yeah.
Right, yeah.
Right, so
That's
I.
I have the exact same rationale, that's my hand. I just make sure that's
No, I just use this grants.
Does he have FBS?
He has great ideas.
So he had an ORIF done.
So now I was gonna.
At 74, like a head
Right.
ORIF.
So I'm like, I think every year should be better,
Right,
but
so I'm like,
that's how he powers.
obviously, wow.
So I'm like, what, I don't know. Do I use the FCR or that's like.
Right, so Rick's are, and actually refer to
Does he have an FCR?
and both of us were like.
But he has to fuse wrist, it doesn't matter.
Yeah, but.
Look, yeah, they one out of the OR, that's okay. It
Since
wasn't like,
FCR went
like
before I.
hey, like things are good and things like that. It was like.
But-
Well, I said.
No, just all those like.
I guess
That probably should
I don't know what happened.
The nerve, right, so this is the problem with that, now we're having.
Yeah, 4 days.
It's cool though.
Like, that's actually like a miracle.
Yeah.
Right, let's just figure it out. It's a miracle.
Well,
She's actually like, oh, we're still have to wait.
I guess I do have.
So I have it on for next Wednesday.
Totally expensive.
I'm gonna try to get a separate room away from.
It's fun.
Thanks.
All right, guys. Enjoy it.
Later on, thank you so much.
Yes, sir. I'll see you in February. We'll
Yeah,
talk.
I'm sure we will.
Maybe I can, we can have a little tour in Macon and down there.
Yes, for sure. So long story short, is,
What?
I don't know for next Wednesday, hope outside your block.
You're coming for another lap on my
Coming
surface.
over, I wanna
No one
see how we do with that.
No,
that
no,
Jeff-
no, who are you
I don't think
replacing?
we was talking about it. And then Sarah said you also had like some elevate.
This is not.
That's fine. My clinic's done it one day.
I was getting my invitation.
No, it's not. That's why I go, damn, I go, well, so I had that 4-part fracture. So I had that 4-part fracture on the day. I go, man, I apologize. I have
So
so.
I would be so excited.
One of which is that-
I would be so
And I was
excited.
like, I apologize. I was like, I'm sorry. Can we get it out? I had a person who's 40.
Yeah,
It's the thing, like, you're getting a replacement.
we just talked to Roberta about it as like.
And so like, I just like, look, I don't know what to tell you. Like, bitch, got magic. And I was like, part of it was like, magic. I'm happy to go tell her to go find someone else. Grab the back.
Yeah, let me just talk to Roberta.
I was like, well, you and I need to be strong. Like, I'm happy to like, look, if you actually want to team this shit, then you guys can go for yourself. Because two of us, as you and I both know, stay late and do all this. I'm not gonna get pitched out. You having a bad surgery by someone else.
We do like much procedures.
And I meant to tell you, I saw the guy, you may not remember.
I did not first.
you did like a cute little tunnel with a step on the guy, and like you asked, you said it to me because you like, you can't straighten your two fingers. It's not like, no, it's not, no, it's nothing. They fucking mess up the higher league. And I was like, I had, that was I was like, I had to go get some haircuts. I was like, sure, this is completely unrelated to any of your shit. Sure enough, I mean, his biggest issue is you can't straighten his fingers. I'm like, sir, I was like, sometimes you have selective whatever, the radial nerve or something higher up. It's not. No, it's like, yeah, that's why it said like, you're not something else, but you guys meant extension. It said flexion, like you can't flex. But if you had this, yeah, his last two fingers wouldn't do that. And I'm like,
I thought it was.
no, that's not. It's just radial nerve. Something's up higher. Sorry.
I like.
Oh, and I saw the guy actually.
He's that guy, the reason guy.
He is pretty good. I also just saw the guy that you sent me. He was like the skateboarder dude. He has an elbow with his elbows dislocated. He's a total skateboarder.
Oh, the guy who keeps just.
Yeah.
Yeah.
He just uses MCL or reconstruct.
Oh, you
No, NBC. He's got both.
Is the one he's chronically dislocated, he's dislocated like multiple times.
Yeah, but it's actually, so everyone's like, they got it, the other side, but I was like, no.
Yeah, it is. He like I can rotate him off.
I know, that's his NBC coach.
And I can rotate him off. Like wow.
But his NBC, it's both, because his NBC is out.
You're gonna reconstruct it.
I was gonna reconstruct